Hi, I'm Dr. Brian Kaufman, a retired family doctor and a CLL patient myself, and the Chief Medical Officer, Executive Vice President, and co-founder of the nonprofit CLL Society. And today I'm going to be speaking to you about some of the most important papers that came out of the American Society of Clinical Oncology's annual meeting held in Chicago. The paper I'm going to talk about now was a follow-up on the ASCEND trial, looking at 4 years of data. Its official title was Acalabrutinib versus Rituximab plus Idelalisib or Bendamustine in Relapsed Refractory Chronic Lymphocytic Leukemia, or CLL. ASCEND results at 4 years of follow-up. So at the American Society of Clinical Oncology, or ASCO for short, annual meeting, always held in Chicago, in 2022, we received the 4-year follow-up on the ASCEND trial. The trial compared acalabrutinib. Acalabrutinib is a bruton tyrosine kinase, or BTK inhibitor, that is similar to ibrutinib, that has revolutionized the treatment of CLL. And they compared its activity to the treating doctor's choice of rituximab plus Idelalisib. Idelalisib is a PI3 kinase inhibitor that also blocks the B-cell signaling and is very effective in its management of CLL, but has more side effects and is harder to manage and harder for patients to tolerate and take long term. So it was that with rituximab. Rituximab is a monoclonal antibody which, when added to other therapies, improves their outcome. Or the doctor's choice of rituximab plus bendamustine. Bendamustine is an old school chemoimmunotherapy that is quite effective in CLL, but studies have shown that it is less effective than ibrutinib in large studies, and it is less potent than FCR, but also less toxic than FCR. FCR is fludarabine, cyclophosphamide, and rituximab, which is the most effective chemoimmunotherapy for patients who can tolerate it, but they have to be younger patients and they have to be sensitive to it. So that's a long introduction. Let's look at the results of this trial. There were 310 patients involved. Half of them, 155, received acalabrutinib. And of the other half, the vast majority, the doctors chose to use Idelalisib and rituximab, 119, with only 36 getting bendamustine and rituximab, or BR for short. The median age was 67. Deletion 17p, a bad prognostic marker, was found in 15% of the patients. 3/4 of them had unmutated IgHV, which is a bad marker, and 3/4 of them had an advanced RISE stage. What was found was that acalabrutinib significantly prolonged progression-free survival versus either Idelalisib, rituximab, or bendamustine and rituximab. For most statistical analysis, since there were so few patients who got the BR, the bendamustine and rituximab, those two were combined together. Let me give you an example. The 42-month progression-free survival rate, so the number of patients who were still alive and their disease had not progressed after 3.5 years, was 62% for those on acalabrutinib versus 22% for those on Idelalisib and rituximab, and 5% for those on bendamustine and rituximab. In patients with deletion 17p, that bad prognostic marker for which chemotherapy doesn't work, median progression-free survival has not been reached at this point for acalabrutinib, but it was reached at 13.8 months for Idelalisib, rituximab, and bendamustine rituximab. Progression-free survival was more favorable for acalabrutinib in all subgroups analyzed, including whether you looked at the patient's in terms of their age, their gender, the status of their IGHV mutation, their TP53 status, and whether or not they had deletion 17p. Across all these subgroups, it worked better. Let's look at median overall survival. How many patients stayed alive? And the good news is, because of the options to try different therapies when one therapy has failed, median overall survival has not been reached in both arms. 42-month overall survival was 78% for those who started with acalabrutinib versus 65% for the Idelalisib Rituximab BR. Overall response rate was 83% for those on acalabrutinib versus an almost identical 84% for Idelalisib Rituximab, Bendamustine Rituximab, reminding us that we are not interested in how many patients initially respond to therapy, but how deep and durable those responses were. Adverse events led to drug discontinuation in almost 1 out of 4 on acalabrutinib, but in 2/3 of those on Idelalisib and Rituximab, and 17% of those on Bendamustine and Rituximab. We're particularly interested in certain adverse events or side effects, and those included atrial fibrillation and flutter, which was higher at 8% in the acalabrutinib arm compared to the control arm of Idelalisib, Rituximab, and BR. Hypertension, again, 8% in the acalabrutinib arm versus 5% in the other arm. Major hemorrhage was equal in both arms, 3% versus 3%. And severe, or what are called grade 3 or higher infections, were also identical at 29% in both arms. So what can we conclude from this? Well, to no one's surprise, acalabrutinib was a better choice for patients regarding progression-free survival. It came with fewer side effects leading to drug continuation compared to Bendamustine plus Rituximab, or with Idelalisib plus Rituximab in relapsed refractory patients. There was no statistically significant difference in overall survival, but there was a trend beginning to show favoring acalabrutinib. There is every reason to be confident based on the more mature practice-changing data that was found in the Alliance trial, where ibrutinib was studied with or without Rituximab versus Bendamustine or Rituximab, that future analysis will prove that choosing acalabrutinib also increases how long those with CLL live. In other words, it actually improves overall survival. While not groundbreaking, it is confidence building to see longer follow-up data now for approximately 4 years for acalabrutinib. And this is also a study that compared it to another novel agent as a comparator, which is exciting and important research. We provide you the link to the actual abstract, and we have more information on the ASCEND trial and the Alliance trial on the website. Thank you for listening. Stay strong. We are all in this together.